Okay, now we're starting topic 9, part 2. We're going to talk about disorders of the adrenal glands. But first, let's review the adrenal glands. So the adrenal glands are involved in producing hormones that help the body deal with stressful situations. There are two parts of the adrenal gland, the inner medulla part, which is really modified neurons, and these secrete catecholamines, epinephrine primarily, and to a lesser extent norepinephrine. The cortex is the outer part, and this secretes steroids. And the three main corticosteroids that it secretes are aldosterone, cortisol, and then some androgens. So we're going to look at a couple of these. So aldosterone is secreted by the adrenal cortex in response to the renin-angiotensin-aldosterone system, in response to low plasma sodium levels or high plasma potassium levels, as well as in response to ACTH from the anterior pituitary in response to stress. Aldosterone acts on the kidney tubule cells to cause sodium reabsorption and at the same time potassium secretion. It does this by causing production of sodium potassium ATPase, so it causes transcription of a sodium potassium ATPase as well as a luminal sodium channel. Conn's disease is a disorder that where we have a aldosterone secreting adenoma, so it causes hypersecretion of aldosterone. And this is going to result in then hypernatremia, because we're going to reabsorb too much sodium into the blood, hypokalemia, because we're going to waste potassium. Potassium is going to go out in the urine. Water is going to follow that sodium, so this is going to result in an increased blood volume and hypertension. Cortisol is released from the adrenal cortex in response to ACTH from the anterior pituitary. This hormone is essential for life and helps the body to resist stress. It is a catabolic hormone, so it breaks body stores of glycogen down to raise blood glucose levels. In addition, cortisol also acts to suppress inflammation and the immune system. It will break down body proteins in order to promote gluconeogenesis to make new glucose, so that also will raise blood sugar. It enhances the effects of the sympathetic nervous system, and it breaks down fats and releases those fatty acids into the blood. Okay, so let's look at a couple of the tests for adrenal function. We can look at blood levels of cortisol, aldosterone, and ACTH. We can do a 24-hour urine collection to measure those levels. We can do a stimulation test with ACTH. So we can give ACTH, and if the adrenal cortex doesn't respond to ACTH, then we know that we would have a primary disorder. We can give a dexamethasone suppression test. And this is to see if we have negative feedback suppression of ACTH. So when we give dexamethasone, do we see a decrease in ACTH? If we don't, then we might have a secondary disorder where the anterior pituitary is producing too much ACTH. And then another test we can do is like a stress test, a hypoglycemic stress test. So we can give insulin to induce hypoglycemia and then see, so that should create a stress response, which would increase corticotropic releasing hormone from the hypothalamus, which then will cause the release of ACTH and cortisol secretion. And we can look if any one of these or more seems abnormal. Okay, so let's look at adrenal cortical insufficiency. So a primary adrenal cortical insufficiency is also referred to as Addison's disease. And this is caused by autoimmune destruction of the adrenal cortex. Secondary adrenal cortical insufficiency is going to be due to a problem of the pituitary gland, so hypopituitarism or maybe surgical removal of the pituitary gland. A tertiary adrenal insufficiency would be due to a problem with the hypothalamus. We can also see adrenal cortical insufficiency with a rapid withdrawal of glucocorticoids. And let me explain how that would work. So if we've been giving a patient long-term steroids, long-term corticosteroids, then the high level of cortisol in the blood is going to inhibit the release of ACTH from the from the pituitary. Over time, the low levels of ACTH is going to not stimulate, because it's low, not stimulate the adrenal cortex. So then the adrenal cortex will atrophy without that stimulus of that tropic hormone. So then if you suddenly withdraw cortisol that you've been giving exogenous, then the patient's blood levels of cortisol become really low, and their adrenal cortex, because it is atrophied, is not going to make it rapidly enough. So if a person is on long-term treatment with corticosteroids, you want to taper the dose so that their blood levels of ACTH come back up and start stimulating their adrenal cortex to grow by hypertrophy and hyperplasia and produce more hormones again. Okay, so let's look at the manifestations. We would see anorexia and weight loss, weakness and fatigue, some GI symptoms such as anorexia, vomiting, diarrhea, because cortisol raises blood glucose levels. Okay, sorry about that. Okay, because cortisol stimulates, raises blood glucose levels, we'd see hypoglycemia if we don't have enough. We'd also see hyponatremia and hyperkalemia, as well as hypotension. Now, this is going to be more an issue in primary adrenal cortical insufficiency than, say, secondary. And that's because some of these effects is due somewhat to aldosterone release. Okay. Now, cortisol has some mineralocorticoid properties like aldosterone, but aldosterone is the primary one. And if you remember, aldosterone secretion is regulated not only by ACTH, but primarily actually by the renin-angiotensin-aldosterone system. So if you had a secondary adrenal cortical insufficiency and your ACTH was low, there would still be a stimulus for aldosterone secretion. But cortisol is only released in response to ACTH. So if ACTH is low, it's going to be most affected. But if you have a primary disorder, in other words, it's within the adrenal cortex and it is hyposecreting both hormones, then you're going to see a more pronounced effect of hyponatremia, hyperkalemia, and hypotension. Now, you can also see hyperpigmentation of the skin if ACTH is high. So if it was primary, then cortisol and aldosterone are low, and then there's no negative feedback to inhibit ACTH. So ACTH would be high. And ACTH stimulates melanocytes, which causes the pigmentation of the skin. Now, if it was secondary adrenal cortical insufficiency, that would be caused by a low ACTH. In that case, you would not see hyperpigmentation of the skin. The treatments are going to be glucocorticoids in primary and secondary, and mineralocorticoids in primary. Sorry, realizing that's written kind of confusingly. The point I'm trying to make is you would need glucocorticoids for both primary and secondary, and you would need the addition of mineralocorticoids only in primary, but not in secondary. An acute adrenal crisis is a life-threatening condition, and this is precipitated by like illness or stress in those with Addison's disease. Okay, so or partially untreated Addison's disease. And this can result in vomiting, muscular weakness, severe hydration, and this can lead to hypotension and vascular collapse, and that's what makes it life-threatening. Okay, Cushing's syndrome. Cushing's syndrome refers to the manifestations associated with excessive level of cortisol, regardless of the cause of the high cortisol levels. So there's different types. Let's look at each of these. So Cushing's disease, this is specific. This refers to when you have Cushing's syndrome caused by excessive secretion of ACTH by the anterior pituitary. This will also be considered a secondary Cushing's because it's caused by ACTH. So Cushing's disease is caused by excessive secretion of ACTH by the anterior pituitary. The adrenal form, which would be primary, is when we have excessive cortisol secretion from an adrenal tumor. Paraneoplastic. This is another condition where it's not in the pituitary, but you have extra pituitary malignant cortisol secreting tumor, such as from the lung, or you could have an ACTH secreting tumor, not from the pituitary, that is causing an excess in cortisol secretion. And that, in fact, that's probably the more likely cause, ACTH rather than cortisol secreting tumor. And then you could have iatrogenic, and this is due to long-term glucocorticoid treatment. So you may know somebody that's on long-term steroids, maybe they have severe asthma, and they develop the manifestations of Cushing's from taking long-term steroid treatment, such as prednisone. Okay, so manifestations of Cushing syndrome. You have weight gain with altered fat metabolism, and the altered fat distribution results in like a protruding abdomen, round face, subclavicular fat pads or buffalo hump. See, I think I said round. Yeah, round or moon-shaped face. Glucose intolerance, because we're going to have high blood glucose levels to too much cortisol. Muscle wasting and weakness. And we have really thin extremities, so arms and legs are thin, but the fat distribution is more central. Osteoporosis, because we break down bones to make more glucose, we break down body proteins. Immune suppression and poor wound healing. And then we can also have a mineral corticoid effect, in other words, the effects of like too much aldosterone if it was caused by ACTH. And hyperpigmentation of the skin if it's due to an increased ACTH. Because remember, ACTH stimulates melanocytes. Okay, and this kind of just compares and contrasts Addison's with Cushing's. They're kind of essentially mainly the opposite, so you can look at those for yourself. Hypoglycemia versus hyperglycemia and so forth. Okay, the adrenal medulla, that's the inner part of the adrenal gland, and that's made up of those specialized neurons called chromaffin cells, and they secrete catecholamines, epinephrine and norepinephrine, into the blood, and this enhances the fight or flight response. Some of the things this hormone does is it raises blood glucose levels. It causes blood vessels to constrict. This is going to raise blood pressure in the heart to beat faster. This is going to help to divert blood to the brain, heart, and skeletal muscle. The only disorder we're going to discuss for the adrenal medulla is a phagocytoma, and this is when we have tumors of the chromaffin cells that secrete too much catecholamine. And the signs and symptoms or manifestations are related to the chronic effects of catecholamine secretion. So, such as hypertension, tachycardia, and so forth. Okay, skipping ahead, we're going to talk about the regulation of calcium balance and parathyroid hormone. So calcium, blood levels of calcium are going to be a reflection of how much you take in, how much is absorbed by the GI tract, and how much is excreted by the kidneys. The two major hormones that regulate calcium are parathyroid hormone and vitamin D. So if blood levels of calcium are decreased, this is going to cause the parathyroid glands to release parathyroid hormone. Parathyroid hormone acts on the bone to break down bone to release calcium, acts on the kidney to decrease calcium elimination, while at the same time increasing phosphate elimination. So when the bone is broken down, it releases calcium and phosphate, but the kidneys are going to decrease the elimination of calcium or reabsorb more calcium but increase phosphate elimination. So this is a way you can raise blood calcium levels without raising phosphate. The kidneys also activate vitamin D, which is going to enhance calcium absorption from the gut. Hypoparathyroidism is a condition in which, is caused by a congenital lack of parathyroid hormone or parathyroid gland. So you're born with an insufficient parathyroid gland or glands. Surgery or radiation in the neck region. Maybe you had your thyroid removed or radiated and you damaged the parathyroid glands. A tumor or autoimmune destruction of the parathyroid glands. Okay, the results of low parathyroid hormone is going to cause hypocalcemia because we're not activating vitamin D, so we're not getting enough calcium into our blood. Weak cardiac muscle, and also we're not breaking down bone as much to release calcium into the blood. It's also going to result in weak cardiac muscle contractions, and this will result in hypotensions and signs of cardiac insufficiency. Now, the reason why the contractions are weak is, if you remember, cardiac muscle cells require extracellular calcium to come into the cell for a calcium-induced calcium release. So if we don't have enough calcium extracellularly, we're going to see weak muscle contractions. However, hypocalcemia causes an increased excitability of nerves, and this can result in things like skeletal muscle cramps or tetany, laryngeal spasm, paresthesias, hyperreactive reflexes. On the skeletal system, a chronic deficiency of parathyroid hormone can result in osteomalacia and bone pain. And this is because we actually have chronically low levels of calcium. Hyperparathyroidism can be caused by a benign pituitary tumor. It can also be caused as a secondary response to renal failure, or it could be caused by a paraneoplastic syndrome. Primary hyperthyroidism, so this is due to a tumor, like of the parathyroid gland producing too much parathyroid hormone. This is going to result in hypercalcemia. It's going to result in forceful cardiac contractions because we have lots of extracellular calcium coming into the cell. It's going to increase contractility. It can cause osteoporosis because parathyroid hormone is going to break down the bone. And it's going to cause a predisposition to kidney stones because we have so much calcium in the blood. Now, secondary hyperparathyroidism, this is going to be caused by an increased parathyroid hormone secretion in response to hypocalcemia. So this could occur like with kidney failure. So if you have kidney failure and you have low calcium levels because you're not able to activate vitamin D, the low calcium levels is going to stimulate more parathyroid hormone. And parathyroid hormone is going to increase and it's going to break down bone. So it's going to continue to break down bone, but we don't have enough, and the kidneys also can't absorb enough calcium. So we can have high parathyroid hormone and at the same time hypocalcemia and osteoporosis. Okay, and then finally, our last endocrine disorder we're going to discuss is diabetes mellitus. So first let's look at a little bit about glucose metabolism and fat metabolism and storage. So glucose is broken down to CO2 and water in the presence of oxygen inside the mitochondria of the cells. This is called aerobic glycolysis. Now other tissues can utilize other fuel sources, but the brain and nervous system need glucose exclusively. After a meal, glucose is removed from the blood and gets stored in the liver and skeletal muscle as glycogen. And this is referred to as glycogenesis. And this is in response to insulin. When blood glucose levels fall, liver cells can break down that glycogen and release glucose into the blood. This is called glycogenolysis. Liver cells can also synthesize glucose from amino acids, glycerol, and lactic acid, and this is referred to as gluconeogenesis. Fat is the most efficient form of fuel storage. We can store a fair amount of fat, keep it around for energy. They're a major source of energy in the body during rest and with moderate physical activity. With high levels of physical activity, we need glucose. If we have excess dietary carbohydrates and proteins, they get converted to triglycerides and they get stored as adipose tissue. When large amount of fatty acids are needed for energy, which can occur like with diabetes mellitus or fasting, protein restrictions, the liver is going to convert them to ketones and releases them into the blood. And this can lead to a condition called diabetic ketoacidosis. Proteins are going to be needed to make all body structures such as enzymes, contractile proteins, bone matrix, connective tissue. There's very little storage of excess amino acids, so if we have excess, then those amino acids get converted to fatty acids, ketones, or glucose to be used for fuel. Because fatty acids cannot be converted to glucose, the body will break down, it can break down its own body protein and convert the amino acids to glucose when metabolic needs for glucose exceed the intake. So insulin is the primary hormone to regulate blood glucose levels. And insulin is released by the beta cells of the pancreatic islets. It is the only hormone we know of that directly lowers blood glucose levels. And it does this by enhancing the transport of glucose into body cells, as well as countering the metabolic activity that would enhance blood glucose levels. So its main effects are to promote glucose uptake into target cells. Now, this would be except for like red blood cells and the nervous system cells, neurons, because they don't need insulin in order to take glucose up into their cells. It promotes glycogenesis in the muscle and liver, so for storage, and it's going to inhibit glycogenolysis. It encourages lipogenesis and inhibits lipolysis. It inhibits gluconeogenesis in the liver. It acts to increase protein synthesis and it inhibits protein breakdown. And it enhances the use of glucose and fatty acids for fuel. So we think of this as an anabolic hormone in that it's a hormone that's released after eating and is going to enhance uptake and storage of excess fuels. Glucagon is released by alpha cells of the pancreatic islets, and it is a hyperglycemic agent, so it has opposite actions as insulin. Its major target is the liver, where it promotes glycogenolysis, so the breakdown of glycogen to glucose, gluconeogenesis, the formation of new glucose from amino acids, the release of glucose to the blood from liver cells. This is going to raise blood glucose levels. And in high concentration, glucagon also stimulates the breakdown of fats, and that allows fatty acids to be available as fuels. There's some other hormones that we'll look at briefly here. Amylin, it's released by beta cells, and this is going to slow glucose absorption in the small intestine, and it suppresses glucagon secretion. Somatostatin, released by delta cells, that decreases GI activity and suppresses both glucagon and insulin secretion. And then we have other counter-regulatory hormones. These are hormones that are counter-regulatory to insulin, so they're all going to act to raise blood glucose levels during periods of limited glucose intake or excessive use. So in addition to glucagon, we also have epinephrine, cortisol, and growth hormone. These are all hormones that will raise blood sugar levels. So obviously it's important to maintain blood sugar levels because that's the only source of fuel that neurons can use. Okay, so now we're going to look at diabetes mellitus. There are different types of diabetes. I should go back here to this other slide. You can look at some of the classifications by etiology. The first one we're going to look at is type 1. Type 1 only makes up about 5 to 10% of diabetics, and it more commonly occurs, or its onset more commonly occurs in children and adolescents. So about 75% of type 1 patients get diagnosed before the age of 18. Type 1 is characterized by destruction of beta cells, leading to an absolute insulin deficiency. We also have decreased production of amylin, which leads to increased glucagon release. So glucose cannot be taken up into the cells. This results in hyperglycemia and the breakdown of fats and proteins. Because we can't get glucose into the cell, we're going to break down fats and proteins for energy. And that's going to lead to the buildup of keto acids, and these patients are going to be prone to ketoacidosis. Oops, let me go back. Okay, the causes. For type 1A, this makes up about most, 90 to 95% in the US and Europe. This is thought to be due to a genetic predisposition with an environmental triggering event, such as a virus, and a T cell mediated hypersensitivity reaction that's against those beta cell antigens. Type 1B is idiopathic, but there seems to be a strongly inherited tendency, with most people being of African or Asian descent. The type 1 diabetes, there's often a long preclinical period with abrupt onset of signs and symptoms when their pancreas kind of gives out. Type 2 diabetes mellitus makes up about 90 to 95% of all diabetics. So most diabetics are the type 2. And this is where we have hyperglycemia due to a relative rather than an absolute insulin deficiency. In other words, the insulin's not all gone, but the cells are not responding to insulin. The onset is slow and insidious, and usually diagnosis occurs after 40 years of age. Although we are seeing an increased incidence of teens and young adults brought on probably by the obesity and sedentary lifestyle that we're seeing more of. Type 2 diabetes is associated with obesity, with about 90% of patients being overweight. So metabolic abnormalities include that insulin resistant, so failure of the target tissues to respond to insulin, increased glucose production by the liver, so we have some kind of impaired response to glucagon, and impaired insulin secretion by the pancreas. Okay, so what causes it? We think that type 2 diabetes is a combination of genetic predisposition, behavioral, and environmental factors. So most type 2 diabetics are obese, or at least overweight, with a genetic predisposition to beta cell dysfunction, leading to deranged insulin release. Other factors include obesity and physical activity. As I mentioned, about 90% of type 2 diabetics are overweight, and that central obesity is more of a risk factor than peripheral obesity. I have a picture of the guy here. Next slide. So central obesity as opposed to peripheral, like hips. So metabolic syndrome. Metabolic syndrome is a name for a group of risk factors that occur together and increase the risk of not only type 2 diabetes, but also coronary artery disease, and stroke. And it is characterized by having 3 or more of the following. So abdominal obesity, high triglycerides, low HDL, a high blood pressure, and a high fasting blood glucose level. Okay, there are other types of diabetes mellitus, which include causes from genetic defects in beta cell function, genetic defects in insulin action, diseases of the exocrine pancreas, such as pancreatitis, or cancer, or cystic fibrosis. Remember, all these things could damage the pancreas and then could lead to destruction of the pancreatic islets. Endocrine disorders, acromegaly, remember, caused by growth hormone hypersecretion, can lead to high blood glucose levels, as well as Cushing's syndrome can also lead to high blood glucose levels. We also have gestational diabetes, and this is where we have glucose intolerance with the onset or first recognition during pregnancy. That's not clearly type 1 or type 2. Okay, let's look at the clinical manifestations of diabetes. We have a rapid onset in type 1, or insidious onset usually in type 2. There are three classic signs of diabetes mellitus called the three polys. Polyuria, which is excessive urination. And this is caused by when you have high blood glucose levels. This is going to make it so you cannot reabsorb as much water in the kidney tubules. So essentially the glucose is keeping the water with it, and it's all going out in the urine. We also get polydipsia. This is excessive thirst. So we have high blood glucose levels is also going to pull water out of the cells, including those of the hypothalamus, which would stimulate the thirst mechanism. And then polyphagia, this is excessive hunger, and this comes when we have depleted cellular stores of carbohydrates, fats, and proteins, and this results in cellular starvation, leading to increased hunger. We usually do not see this, though, in type 2 diabetes mellitus. Okay, some other manifestations. We can see weight loss and ketoacidosis in type 1 diabetics. So we have loss of body fluids due to that osmotic diuresis, as well as vomiting, which is due to ketoacidosis, and loss of body tissue because we're going to break down fat and protein for ATP production because we're unable to get glucose into the cells. Other signs that often prompt type 2 diabetics to seek medical attention include such things as recurrent blurred vision, and this is due to the lens and the retina being exposed to this fluid with a high osmolality. Fatigue, this is related to poor use of food products. Paresthesias, so we have dysfunction of peripheral sensory nerves resulting in that pins and needles. Skin infections, which are more common in type 2, and then yeast infections. Okay, jumping ahead, let's look at diabetes mellitus. So with diabetes mellitus, the goal is to normalize blood glucose in order to prevent complications. So through diet, you're going to try and maintain near normal blood glucose levels. You're going to try and maintain optimal lipid levels and get adequate calories. Type 1 is probably going to have to focus on regular meals, and it's going to have to fine-tune it based on blood glucose levels. Type 2 may focus on weight loss, and actually a lot of weight loss can even increase the insulin sensitivity of the cells. Exercise. Type 2, this is going to be important to decrease body fat, control weight, and this will also help to improve insulin sensitivity. And then medical management. We're going to need exogenous insulin replacement therapy, definitely for type 1, but it may be needed for some type 2 patients. And there's a variety of treatment plans associated with that. And then we can use some anti-diabetic agents for type 2. And this is on the next slide. Just glance over it, but you don't need to know that specifically. And then finally, pancreas or islet cell transplant. Okay, now we're going to take a look at acute and chronic complications of diabetes mellitus. An acute complication is diabetic ketoacidosis, and this results from insulin deficiency and an increase in insulin counter-regulatory hormones such as glucagon. This is mainly a problem in type 1 diabetics, and it's going to result in really high hyperglycemia, and this is going to cause osmotic diuresis, as well as increased fat mobilization and the formation of ketoacids, and this is going to result in metabolic acidosis. So in this case, we're going to have extremely high blood glucose levels with low bicarbonate, because bicarbonate is going to be tied up by all the extra ketoacids, and a low pH. The urine will be positive for ketones. And this type of condition can be initiated by infection or stress, or it may also result from an error in insulin dosage, infection, change in diet, or alcohol intake, or exercise. Okay, so some of the manifestations of diabetic ketoacidosis. We get the polyuria, polydipsia, and dehydration. This is going to result in thirst and dry and rough oral mucous membranes, warm, dry skin. the skin is going to be warm due to vasodilation as a result of the acidosis. The acidosis is going to cause vasodilation. You're going to get rapid, deep respiration, the Kussmaul's respiration, acetone breath related to the keto acids. We're going to see lethargy and decreased responsiveness due to that acidosis. And this could lead to loss of consciousness, loss of sympathetic tone, and vasodilation. So that results in the red, warm skin. Okay, so that loss of sympathetic tone that I mentioned was due to the acidosis. Electrolyte imbalances, including that can cause abdominal cramps, nausea, vomiting, tachycardia, and weak pulse, as well as CNS depression that can range from fatigue eventually to coma. Okay, you want to treat diabetic ketoacidosis by giving insulin to lower blood glucose levels. However, and you also want to correct the acidosis and any other electrolyte imbalances. So in addition to giving insulin, potassium is often also given with insulin, as well as bicarbonate for the acidosis. Okay, another condition with really high blood glucose levels is hyperosmolar hyperglycemic non-ketotic syndrome. And here we have extremely high blood glucose levels, hyperosmolarity of the blood, and dehydration, but in this case it's without ketoacidosis. And this condition occurs more in type 2 diabetics, usually in older patients. So we get really high blood glucose levels leading to osmotic diuresis, a large loss of glucose in the urine, polyuria, dehydration and potassium loss, low blood volume, and low perfusion pressures. So the signs and symptoms, we're going to see severe hyperglycemia, weakness, dehydration, excessive thirst, some neurological signs, including hemiparesis and aphasia, a Babinski reflex, fasciculations of the muscles, seizures, and coma. Now, this is more insidious in onset and often can be confused with cognitive impairment or strokes in older patients. This is treated with food replacement, insulin, and potassium. On the other end of the spectrum, we have hypoglycemia or insulin shock. This is where we have extremely low blood glucose levels. It's most often caused by too much insulin replacement in a type 1 diabetic. But it can also be caused by dosage error following strenuous exercise, vomiting, skipping a meal, an insulin-producing tumor, or drugs that stimulate insulin secretion, or maybe a defect in the glucose counter-regulatory controls. So symptoms, we're going to see increased heart rate, pallor and sweating, trembling, nervousness, and anxiety. This is because we're going to see an increased sympathetic nervous system tone, headache, confusion, dizziness, loss of coordination, slurred speech, and convulsions. This can lead to loss of consciousness and coma if untreated, and this is treated by giving glucose. So you give glucose in a concentrated carbohydrate source. You can also give glucagon to cause a breakdown of body stores of glycogen, and the patient's unconscious, you're probably going to give an IV solution of 50% glucose. Okay, we also have a lot of chronic complications of long-term diabetes mellitus, and these include disorders of the microvasculature, such as neuropathies, nephropathies, and retinopathies, disorders of the macrovascular, such as coronary artery disease, cerebrovascular disease, peripheral artery disease, diabetic foot ulcers, infections. The most important factor is the level of chronic hyperglycemia. So how high has been the blood glucose levels and over what amount of time has these blood glucose levels been uncontrolled. So the microvascular disease is due to changes in the capillaries and small arterioles. This can lead to a thickening of the capillary basement membrane, as well as hyperplasia of endothelial cells and the development of thromboses. This can lead to ischemia and hypoxia, and particularly susceptible are the retinas and the kidneys, and this can lead to diabetic retinopathy for the retinas or diabetic nephropathy in the kidneys. So diabetic retinopathies are the leading cause of acquired blindness in the U.S. So we have abnormal retinal vascular permeability, we have the formation of these microaneurysms, new blood vessel growth. It can also lead to hemorrhage and scarring within in the eye. This hemorrhaging can increase the pressure in the eye and lead to retinal detachment. Diabetic nephropathies are due to damage to the glomeruli. This can lead to protein loss or albuminuria, so albumin in the urine, a progressive decline in GFR with kidney failure, hypertension, and this is the most common cause, if you remember, of end-stage kidney failure. We can also have diabetic neuropathy, and this is where we have nerve degeneration and slowed conduction of nerves in both the central nervous system and the peripheral nervous system. And this can lead to decreased function of both sensory and motor nerves, as well as autonomic nerves. So the somatic nerves, damage to them can lead to diminished senses or hypersensitivities to senses. So like, for instance, diminished perception of temperature or pain. It can cause hypersensitivity to touch, burning pains. Autonomic neuropathy, so this is of the autonomic nerves, can lead to defects in vasomotor and cardiac responses, which can lead to like hypotension, impaired motility of the GI tract, impaired ability to empty the bladder, and erectile dysfunction. Okay, other chronic complications. So damage to the larger arteries, we can get atherosclerosis. The high blood glucose levels makes one more prone to atherosclerosis. It damages the blood vessels. And this is going to lead to, or may lead to, coronary artery disease. So we can see that the incidence of coronary artery disease increases with the longer you have diabetes. It is the most common cause of death among type 2 diabetics, so about 20% die of a heart attack. Having diabetes makes you 2 times more likely to have a stroke or cerebrovascular accident. And that can also result in peripheral vascular disease, so that's of the small arteries to the legs and feet. And this can result in ulcers and slow healing, frequent infections. This can lead to gangrenous ulcers and could eventually lead to amputation. So, which leads me to infection and foot ulcers. So diabetic foot ulcers is the most common complication leading to hospitalization in diabetics. And this is kind of due to both vascular and a neurological impairment. So if you have some damage to the sensory nerves, this could, and retinopathy, this can lead to impaired vision and touch, and that can make it more easily that you would damage the skin. So let's say you damage the skin on your feet. You don't even know it. You can't see it. You didn't really feel it. And then hypoxia, because you have impaired blood flow to the foot, and that's going to make the tissues more susceptible to infection once damaged. Pathogens have glucose for growth, so bacteria can use the glucose, excess glucose in the blood for fuel. And the blood supply is compromised, so we're going to see a decreased number of white blood cells in the area to fight infection. And they have impaired function. There's other infections that are just more common and more severe in diabetics, include fungal infections, UTIs, cavities, gingivitis, and periodontitis. Because of the huge risk of infection in the foot, leading to potentially amputation, you have to be specially trained to just cut the toenails of a diabetic. Okay, make sure you take a little bit of time to look at this discussion question. understand what you would see in ketoacidosis versus just high blood glucose levels. Also, kind of think about this scenario. If you find somebody and you might, he's wearing a diabetic bracelet, and he has an insulin syringe in his briefcase. Does he need insulin? What do you think? Why or why not? And think of what are the signs and symptoms that might tell you whether he has a hyperglycemic or a hypoglycemic problem. So I'd suggest that you go to the study guide and compare the signs and symptoms between hyperglycemia and hypoglycemia. Now, obviously, if you don't know what the problem is for sure, and the only way you can know really for sure is to test the blood glucose levels, think about whether you'd rather err on the side of giving the person a little glucose or giving them more insulin. That's all